Good afternoon. I'm Russ Leftwich. I'm joined by Michael Marchant, and we are going to talk for the next 20 minutes about the benefits of payer-provider interoperability and data exchange. I will start out by talking about the problem that we're trying to solve, and Michael will talk about the solution. Possible solution. Getting to the solution. So we're going to focus on the health plan as the custodian of a longitudinal record for the individual. That may sound strange. We're going to talk about that and why maybe it is strange, but it is probably part of the ultimate solution. So as you probably know, the 21st Century Cures Act authorized HHS to produce a series of federal rules. The one that was recently released, referred to as CMS 0057, sounds sort of like a secret agent type, but it's not. It is labeled as the Advancing Interoperability and Prior Authorization Rule, and in that rule they admonish payers to create and maintain this longitudinal record for their individual members. So I'm going to start out by going back to before we had this problem, and I'm going to start before there was data. So does anyone know who the father of modern medicine is, who that refers to? Marcus Welby, if you're that old, or Doogie Howser, or Tony Fauci? No. It's the father of modern medicine is actually Hippocrates, who lived 2,400 years ago. Now, what was modern about that? Well, and what do we still do that's the same? What was modern was that he was the first physician to attribute disease to physical processes, not to some mystical or metaphysical process. And he created the workflow of talking to an individual, to a patient, observing them, and then in your head coming up with a diagnosis. Well, we have a lot of technology that he didn't have. We have pharmaceuticals. We have a tremendous number of tools, but the truth is we still practice medicine the same way. We talk to the patient, examine the patient, observe them and their data, and then we usually come up with a diagnosis in our head. Maybe we get some support, decision support, but I'm going to tell you why doing it in our head is becoming more and more difficult, or probably beyond impossible even now. So if we fast forward 2,300 years to the turn of the century, and we have a family who I can tell you a few things about, not knowing who they were, but I can tell you there were no antibiotics. They didn't take antibiotics. Childbirth was actually safer at home. Mothers died more frequently if they gave birth in the hospital because hospital-acquired infections. Individuals were, they didn't have medical charts. There was no such thing as a medical chart. Medical doctors kept a journal of who they saw every day. And I can tell you these people didn't have allergies because the word allergy wasn't invented until 1904. And the 5 leading causes of death were all infectious diseases. If we fast forward to more recent times and a more modern family, we have thousands of pharmaceuticals. There are thousands of lab tests available in any medical facility. We have electronic monitoring of virtually every body system. We can image the entire body in 3D. We have genomic sequencing that was completed in the whole genome in 2003. And infectious diseases are no longer the 5 leading causes of death, but actually medical errors are the 3rd leading cause of death. And part of the reason is we don't have access to the right data at the right time to make the right decisions. And one of the reasons is there's an incredible amount of data just in the past few decades. So Dr. William Stead at Vanderbilt University created this estimate of the number of facts that exist for every complex decision we make in healthcare. And it's just an estimate, but it's reasonable. And it's the facts that exist, not the facts that we have in our record about this decision. So in 1980, he estimates there were about 10 facts for a complex decision. That has grown exponentially with new technologies. CT scans are new, MRIs are new, genomic sequencing is new. There is a lot of new technology, and with it comes data. So now, in 2024, his estimate is that there are thousands of facts for every complex decision we make in healthcare. The problem is that horizontal line you see at the bottom of this stylized graph at the number 5 is the number of facts that a human can have in their head to make a decision. I think I can do 8 or 9, and I'm sure Hippocrates could, but if there are thousands, then I'm in as hopeless a situation as everybody else, and there is no way we can improve on this without having access to the data, all of the data about each individual that we're treating. That data is also in a lot of places. And I kept the diagram that you see here that I had Dolly Chat GPT help me draw, and I learned my lesson about hallucination because even though I gave the app specific facility names to put into this diagram, it made up names that don't, well, maybe they do exist, I'm just not up to date enough, but in any case, the idea is that for each individual, there are an increasing number of places, already potentially hundreds of places, that individual has data. Not just in the hospital, not just in the clinic record, but in other systems. An average hospital has over 80 systems in its walls, in mobile devices, in wearables, in pharmacies, in DNA sequencing labs. There is a lot of data out there, but we cannot get to it in a lot of cases at all, or when we can, it's a lot of work, and what we get is not always, in fact, often isn't usable data. Never mind data quality issues, it comes in a format that we can't actually use. So the result is, for a lot of the patients we see today, we see a pixelated patient. There are things missing from the picture of that patient because we can't go out and get all of that data. We don't know how to connect to it, and in fact, we don't even know where it is in a lot of cases, and we get this incomplete picture. Now, it's true that there are some individuals who have all of their data in one place, and we do have it, but reality is that the more complex patients get, the more chronic conditions they have, the more likely they are to have data in a lot of different places. You're probably familiar with the statistic that's been quoted for the last few years that the average Medicare beneficiary sees 7 providers in 4 different organizations in a year. The average Medicare beneficiary. So that means there's a lot of data scattered around, and I would posit that those providers that they see don't in general know who the other 6 are, let alone how to get to their data. Who does know who they are? The payer does, because they got the claim for that patient's care. They know who the provider is. They know where the patient has been. They know what happened to the patient in terms of procedures and encounters, and they know what the diagnosis is. That's more than usually any one of those 7 providers that the patient sees knows. What's more, the payer, knowing that, knows that all of the time, if you will. One of the problems for providers, and I was practiced medicine for 25 years, you really only think about the patient when they're face to face with you, and when they come for an encounter or they're in the hospital. You're not thinking about their data or what they're missing in terms of gaps in care when they're not in front of you. However, if the payer has all of that data, then AI can help look for where there are missing opportunities for care, missing diagnoses and so forth. That's the value of having that longitudinal record, even if it isn't all of the clinical data. And so we're not talking about EHRs spliced together to produce a longitudinal record. We are talking about the claims data to begin with being the dots that we can connect to create the picture of the patient that is a complete picture by knowing where that data is and being able to access it. But those are 2 more challenges that we have. This is a map of the United States. That's actually a map of the connections that the eHealth Exchange has across the country. It is reasonably good coverage. It's not absolutely complete, and you could draw the same map for Care Quality and Commonwealth, that there is the theoretical ability to connect to all of those places and get a patient's data. Now, the truth is, what we usually get at the current time is not FHIR data, which is what we're here partly to talk about today, but CDA documents, which are often more than you need to know, and in fact so much so that they're not usable because you can't find what you want in those documents. But what's more, we typically don't know where the individual in front of us actually has data in all of these places. And the process of discovering that and going out to get that data, reaching out to get that data, is not a practical process. However, the payer does know, because they know where the claim came from that generated that data, if you will. So that is the potential of the payers having this longitudinal record for a patient that providers could access when they want to get the data, that the patient can have access to, but the beneficiaries are the providers in being able to provide better and more efficient care, and the patient in getting more efficient care and better outcomes. So with that, I'm going to turn it over to Michael to talk about this potential solution as a provider organization.
Thank you. Mic 1 back. Mic 1 on, please. Try now. Ooh, sorry. Sorry about that. He said, grab mic 1. It will be on. But he didn't know because he's behind the screen. All right, for those of you standing in the back, what I'm saying from a provider perspective might be seen as hearsay or heresy. Is that how you say that, right? So if you faint when you hear a provider talk about this, I'm not taking liability. So there's plenty of seats. Grab a seat. And social engineering is a very interesting thing, because the more people sitting, the more people walking by look and say, they must be saying something really interesting, because there's a lot of people here. Look, we got new audience members. Come on in. Have a seat. She was afraid to faint, so she's going to sit down. So I'm Michael Marchand. I'm the Director for Interoperability and Innovation at UC Davis Health. And one of the things that we're challenged with in healthcare is interoperability. And I've grown up from mainframe to best of breed to, essentially what feels like mainframe again with some of the solutions that we have that try to solve all the problems. But part of what we're doing is not only building better systems and building better interoperability, but those interoperability, especially with FHIR, smart on FHIR applications, come in frame, come in the UI that the provider or the clinician or whomever is working in, and really have enabled more seamless interoperability for functions that may have previously been done in different applications. So for me, and I'm going to go through the slides because transitions are just boring. For me, I look at the interoperability challenge as an identity challenge. The identity of the patient, the identity of the provider or the organization, and how do I know, whoops, I forgot, they went to the hospital. How do I know who went where and had what happen, right? So if I'm a provider today, and if you look at the care equality and the health exchange numbers, the number of queries and documents exchanged are millions and billions and probably trillions of documents. Do you know why? Because we do federated query. So for a patient that shows up in my organization, we look at their zip code, and the day before they show up, we query every organization within a 10-mile radius of that patient's home, looking for, or searching for those nuggets, because we don't know where they might have had care previously, right? So in this example, and again, I pulled this from a different slide. I am not a graphic artist. If you know anybody who's good with slides, please send them my way, because I just take PowerPoint and just make boxes and lines and stuff. And I probably owe somebody a licensing fee for the clip art that I've stolen from over time. So if they ever find me, just know. Anyway, so you look at this scenario. This family's changed insurances. They've changed doctors. Some of the legislation that Russ talked about has enabled some of that payer-to-payer exchange, or that insurance. The insurance companies know about each other. They're exchanging that claims information. So from the provider perspective, is part of the administrative burden, and I think we hear this term a lot, the administrative burden technically for me is figuring out, how do I go find that information? How is that organization connected? And how do I pull that information back in a meaningful way for my clinicians to use in the system of record for us, whatever EHR technology you might be using? So as we move forward, the concept, at least I like alliteration, so I say payer as proxy. So got the two P's in there. There's probably another P I could throw in, but for now we'll just go as payer as proxy. So because I know who the insurance company is most of the time, and again, we're talking about 80 to 90% of the solution, because a lot of the solutions around pop health are based on the fact that you have a primary care physician. Not everybody has a primary care physician. I think we all know that, right? So you miss a significant part of the population. But you do almost always know who the payer is. Again, there's cash pay patients. Again, corner cases we're going to put to the side for now. But if you think about it, most organizations know who the insurance company is when a patient shows up in most circumstances. And again, we're going to put the corner cases aside. So if you look at it that way, all the data standards that exist today that are supported by the technology, and again, if you're using a certified EHR, if you have that technology in place, all these standards are supported. All this interoperability actually exists. I'm going to switch hands. Because I feel like I hold the mic better in my right hand. So all of these frameworks, networks, exchange technologies, standards exist to exchange data. So for the most part, and I've told my CIO this for years, is if I know where they are or where they had care and what their identity is, for the most part, I can probably go pull information. Now, again, I think we've all had various experiences with CCDs and how verbose they may be and whether the quality of the data is good, or do you get more data than you really need? Is it the point in time information you need for the use case that you're trying to pull that data? And again, we're very verbose. I've seen 300-page CCDs exchanged across care quality, the network that we received, and then trying to consume that and make that usable, right? So as we move to FHIR, again, discrete resources, discrete ability to pull specific information, smart on FHIR applications that allow that information to land inside your architecture exactly where it needs to be in frame, so that the clinician, physician, whomever is using the system allows that information to land in that spot. So if we think about this, so if I know who, right? So if my exchange partner now becomes the patient's payer, I don't have to figure out where they went. I don't have to send federated queries. I don't have to do any of that stuff. I just connect with the payer. The payer tells me, here are all the places that this patient has had care. And again, I've made up names here to protect the innocent. There's no real thing that's happening out in the world. This is all in my head. But part of my problem is that I want interoperability to work. What happens today without networked FHIR and some of those other things makes it difficult for us to do this in a meaningful way, which is why even though our organization in the last 12 months had processed more than probably 100 million FHIR API calls across all our resource pool, right? So FHIR is out there. It's working. There are hundreds of apps in every vendor's app store that use FHIR, use Smart on FHIR, that launch out of your application. So when people say FHIR doesn't work, FHIR doesn't work the way you want it to work, which is almost kind of like networked FHIR and the IHE profiles and being able to query and respond, right? So now what this does is it eliminates the need to know the patient's identity. The payer now knows what organizations, and for the most part, I think if you add the breadcrumb in of that payer exchange pathway is, do they support IHE? Are they a FHIR endpoint? Do they publish V2? We know the identities, we know the organizations, and it's really just determining, and if you want to basically put the administrative burden on the payer to be the directory for this kind of activity, they're the ones that most benefit by not having duplicative care. They're the ones that have case managers that should manage patient populations that are not managed care patients. So there's a lot of incentive and cost savings for the payers to actually provide this service. Now, I'm old, so I go back to the time, that's why I said about the fainting, right, is having the insurance company have access to the medical record was like people would fall out of their chairs and go, why would you want to do that? Well, we've had some laws passed in a few years that make it safe so that you can actually move from employer to employer, move to another plan, pre-existing condition protections. Some of those things actually are in place that protect you some. Now, again, I think we all heard at some point the black cloud of the death panels and all that sort of stuff. I can't tell you how insurance companies are going to manage that information, what they have, when they have it. But I do say that this particular paradigm takes a lot of administrative burden off the provider in trying to basically find information. And that's just the patient's expectation. When they show up in the hospital, they show up and say, why don't you know all this? I was just at XYZ hospital across the street. Aren't you connected to them and getting that information? Well, if I didn't know that, or they use their maiden name there and they use their married name at my organization, or they fat-fingered a birthday, my matching algorithm isn't going to find them, even if they're across the street, right? Matching algorithm goes out the door. Payer's in charge of the identity. Payer's in charge of the longitudinal record. And I'll use since everybody wants to talk about AI, I'll go back in time for the last hype cycle item. Blockchain does track and trace really well. Now, whether or not you implement blockchain or not, but part of my job is to find the right tool for the job and then implement that tool to make interoperability work better. And if blockchain might be the right way to do this, and how we can do, because it does consent, it does a lot of different things, because part of the equation, at least in my head, is how can I make real-time interoperability happen that allows the patient to consent? Because I'm in California, and we have implemented lots of fun laws in California because we're special. One of them around reproductive and behavioral health rights or exchange. And essentially, without consent, there's data that we can't exchange that's part of the clinical note or not in discrete fields that is almost impossible without essentially women opting out of exchange altogether if they don't want that data to go to another state, which California has now made law, right? So how can I now embed real-time consent like you do with your bank when you log on to the bank, they send you something. The airlines, shoot, my flight got connected out of Houston. I got a text on the plane that my flight had been connected. So that technology is enabled. That's out there. That's real. I'm probably over time. No, I'm not over time. That's good to hear. So part of this slide, and I stole it from Russ. It's an old InterSystem slide, but basically with FHIR resources, again, part of our interoperability challenge is the right data on the right patient in the right place at the right time for the right use, right? All the rights. Get all the R's. How many, anybody count how many R's that was? I don't know. I didn't count. But I think that's our interoperability challenges. We can send data everywhere or anywhere. Multiple modalities, multiple standards. I showed the slide with all the different standards, which makes it very confusing for people who don't work in this space. But it's not a technology problem. It's an operational problem. It's an ownership problem. It's an identity problem. And from my standpoint, with the flexibility that FHIR gives us, and the implementations that are out in the world, we can solve it, mostly. So I think that's it. Yeah, those are my thoughts. See, I'm very thoughtful. No, you don't need to worry about that. There's just some other considerations. If you want to download the slide, I'm going to give the audience a chance to ask questions because I feel like I'm from New York. I'm talking really fast, so sorry about that. But there's a recording somewhere. All right. Yeah, there's my death panels one. All right. Q&A. Questions? Russ, come on up. Be on stage. Nobody has a question. Any providers in the audience that are scared? Oh, we have a question over here. Yes, sir.
Hi, I'm Jay Sultan. I'm a private consultant. Payers have always known they have the longitudinal data. They've been building these kind of visuals that you're talking about for 10 years. Of course, what they don't have is the clinical data, and they go back and forth depending on where you are in a payer about whether they need clinical data and what they would do with it. But they don't need consent. Now, to your point, some states have specific laws, such as the BH laws in California, the BH laws in New York, reproductive, and so on. Other states have the exact opposite laws, like in Alabama and Texas. But the point is, the payers' rights under HIPAA usually allow them to get all that information and to share it under HIPAA protected rules, for payment or healthcare operations or whatever. So I guess the question I've got is there's nothing, the payers can do this today. The providers largely have not been using the payer access API because, again, that requires that what the government mandated to be published requires using Smart on FHIR. Providers aren't going to have the credentials to log in that way. There is this new mandate, which I think is 3 years out now, that'll provide the provider access API. Are you envisioning what you're describing happening prior to the provider access API? And if so, what part of the mandated technical infrastructure are you proposing to use? Or are we just talking about, hey, once we get the provider API, we'll be able to access this in the way that you described?
Russ, you want to?
So I don't have the answer to all of that. Payers have had the data, but the tendency of people in the U.S. to change payers often has limited the idea of a longitudinal record in the hands of the payer. It wasn't structured in a way that they could use the data for the purposes we're talking about. I'm being told to hurry up. So the provider access API is not what we're depending on, but in fact, you're right. This is the future, not the present, and the final CMS 0057 final rule that was published in January takes effect over the next 3 years. So this is a process yet to be demonstrated that it works.
Yeah, and from my perspective, this is visionary. This isn't something, as you say, isn't happening, but the technology can enable it, and it's really up to organizations to decide that they want to do it or not. And payers are currently not incentivized to manage the patient's identity in the way that we've envisioned, and so that would be part of the solution. So thank you all. Happy to take questions on the side. Oh, go ahead.
Thank you so much. We do have another session starting very shortly, so I do have to skedaddle everybody. We have a couple networking areas, and if you would like to continue the conversation, since this is such a fascinating topic, please make your way over there, and they would be happy to continue the conversation. Thank you all so much.